And I'll share my screen really quickly. Okay, hi everyone, I'm Christina. I'm a second-year medical student at the University of South Carolina. Thanks for attending GOWME's virtual lecture series. If it's your first time with us, GOWME is an educational platform for students and healthcare professionals to explore and interact with wilderness and emergency medicine. We have these virtual lectures where physicians and other healthcare professionals can share their specific fields of wilderness medicine and just kind of introduce everyone to this interesting subfield of medicine. If you haven't already, I'd recommend joining our mailing list. There's a QR code here where we send everything out with our schedules and everything, and I'll also drop a link in the chat. Also follow our socials, especially our YouTube. We will post all the lectures to the YouTube for you guys to watch at your leisure if you can't make a lecture or you want to refer back to something. These are all the lectures we've had so far this semester. So you'll see we're towards the end of it. In April, actually, we'll be having a wilderness medicine class with survival med. So if you're interested in that, that's in our email and on our website. You guys can check it out. Also, Pit Viper has agreed to do a giveaway for everyone who attends our lectures. So make sure you enter that. I'll put a link to the Google form in the chat as well. So a thank you for attending our lectures this semester. And now I'll introduce Dr. Bossert. He's a board certified obstetrician gynecologist in Chattanooga. He's part of the clinical faculty for UT Health Science Center College of Medicine, the Chattanooga Department of OB-GYN, and the director of the OB-GYN Surgical Skills and Simulation Lab. He loves teaching, wellness, the outdoors, and his family. Okay, I will stop sharing my screen and turn it over to Dr. Bossert.
Awesome, thank you so much. I appreciate the intro. Let's see here, and we'll go right into it. All right, well, welcome everybody. I appreciate GOWME in organizing this, and what an amazing organization, especially when you consider that its mission is so robust and just, I don't know, just what an interesting opportunity, what a fun opportunity. So I appreciate the chance to get talking with you. Okay, so I'm a board certified OB-GYN, just like she said, and in wilderness medicine, it's kind of interesting that there's not that many OB-GYNs. There's a handful. I think there's 3 that are in the WEM, and I know one of them. So I don't know. I got to find the other one because it's not a big list, but it's a growing topic when you get into obstetrics, but even when you get into women in the outdoors and women's health as sort of a concentration in the outdoors and into triathlons, and you get into like all these adventure sports and all this other stuff. And so it's an interesting thing to think about just from a general medical education standpoint. But then when you actually add some of these components into what it's like to be in austere environments, it's I don't know, it's not only fascinating, but it's also really quite a huge topic, and it's something that's picking up a lot of momentum. And as an OB-GYN, it's exciting because 1, I'm in wilderness medicine and I'm actively pursuing the FALM right now, and 2, it's exciting because there's not a lot of OB-GYNs, so I get to be an expert in a very narrow field. So it's a niche that has fallen into my lap. So without further ado, we'll jump right into it. I have no financial conflict of interest. Objective. So we're going to talk about differences in pregnancy physiology, which is again a key component. I'm a big believer of you have to understand the why component of everything to really be able to be fully functional and fully operate in the field, right? So the difference between a technician and a physician is the physician understands the why, right? You can train a lot of people, and I used to do this in the military. You train medics. You can train a lot of people to do certain core skills, but you really reach the next level. And this is what I try to do with the medics as well. You reach the next level when you understand the why behind things. So understanding the pregnancy physiology is going to be really important, and that'll help you really interact with what you need to do. Medical history taking that's unique to the gravid condition. Review common obstetrical related conditions and maladies. And then with that, potential contraindications for wilderness travel during pregnancy. And there's quite a few, quite a few. Understand the treatment and management in the austere setting, and discuss a reasonable equipment list specific to obstetrics. And then finally, before we get to a Q&A, we'll close with comments and topics to avoid when conversing with a pregnant patient. And this will be a national public service announcement, so you can get some PSA credit there. So differences in pregnancy physiology. So we'll start with cardiovascular. So there's increased blood volume, heart rate, and stroke volume. So cardiac output, which not surprisingly is based on what we just talked about, increases 30 to 50% by the end of 12 weeks. So by the end of the first trimester, cardiac output has already increased 30 to 50%. And when we get into this, we'll talk about some of the other things, but if you look at a marathon runner's heart, you see all that concentric hypertrophy of the heart. If you do a chest x-ray, as we sometimes do on a pregnant patient for various reasons, you will see cardiomegaly. And this is important because that's not an abnormal finding. Now, how much is, I don't know, but it's always going to be reported as cardiomegaly. But the key thing to remember is, if you look at a marathon runner's heart and a pregnant person's heart in the third trimester, my friend, you can't tell the difference. They look the same because there's that much cardiovascular demand. This is why pregnancy is typically a fit, healthy person's game, if you want to look at an advantage. And if somebody that's out of shape, not cardiovascularly inclined, is going to be at a huge disadvantage. And then age obviously adds to that. Uterine blood flow, so here's another important part, increases from just 50 mLs per minute to 500 mLs per minute by the third trimester. So think about that for a second, 50 mLs to 500 mLs. So you can appreciate that. We'll talk about here in just a second how much the blood volume increases, but you can appreciate how quickly you could exsanguinate from a postpartum hemorrhage or certain conditions that happen in pregnancy. You can exsanguinate quickly. You can exsanguinate within minutes. There's decreased systemic vascular resistance, which is also important, and that's done because it's trying to make, the body's trying to make room for all this extra blood that the pregnant patient is making over time. Blood volume, as I alluded to, increases 40 to 50% by the third trimester, about 2 liters more than a non-pregnant patient. That's a lot, and that's also relevant, as we'll get to in just a second, as that how much extra buffer you have. It's important to remember there's a physiologic anemia of pregnancy, and there's a disproportionate increase in plasma volume over red cell mass. So there's way more plasma than there's red cell mass. So you end up getting this physiologic anemia of pregnancy. And that's important too, because as you recall, the red cell mass and the hemoglobin specifically is where we're carrying oxygen throughout the system. So if your oxygen carrying capacity is decreased, that's relevant because essentially you're starting in somewhat of a hole. Now, there's a lot of discussion and controversy over whether you use ethnicity in our research and management. I will just say, without delving into that, historically, from an ethnicity standpoint, African Americans tend to have a little bit more. So Caucasians or white women tend to have more anemia of pregnancy than African Americans. The population that has the least anemia, some occasionally they do, are the Hispanic population. So again, relevant from you're out in the wild standpoint. We're relevant from a wilderness medicine standpoint, because just from a generalized ethnicity standpoint, you have less of a buffer in certain populations than others. Again, we care about blood loss, so it's not like we're being flippant with it and just say, well, let them bleed, they're Hispanic, let them bleed. No, but you would say, okay, I have an idea of where I'm starting at. So if you already know you're in a little bit of a hole in a Caucasian woman, that gives you an idea. When you're looking at the big picture with this, as we'll get to, which the bottom line is evacuate in a lot of these situations, is to get out as quickly as possible. That's important to have an idea of where you're at if you're trying to really process this in your brain. Typical healthy non-anemic patients, so in pregnancy, without getting too much into details, in the third trimester, a hemoglobin of 11 or more is not considered anemic. So that's a little different than a non-pregnant patient. A non-anemic pregnant patient can lose about 1,500 milliliters of blood loss before showing any signs, symptoms of shock. That's important. Pregnant patients are very similar to a pediatric patient in the sense that they have a lot of reserve and they can tolerate a lot. And then once they actually start to show signs, they drop off dramatically. So therefore, if you see signs and symptoms of hypovolemia, you are deep in the blood loss hole, likely the equivalent to 1,500 in a healthy non-anemic patient, or maybe they only lost 500, but they were already severely anemic to begin with, right? So if you're seeing signs and symptoms of hypovolemia, you're in a deep hole. And also important to remember, just because you don't see signs and symptoms of hypovolemia, don't just assume we're money. We're just going to keep on rolling because it's only been a little bit of blood loss. I don't know many people that would do that in the middle of the woods. They probably would be like, oh my gosh, this person's bleeding, we need to evacuate them, for any patient, especially a pregnant patient. But assuming that crosses your mind, at least know that you potentially are deep in the hole if they're already showing signs and symptoms of hypovolemia. Also important to note is the volume of distribution. So due to the expansion of blood volume, there's a greater volume of distribution that affects most drugs. So some medications require higher dosing or shorter intervals. And I could give you a whole list of them, but just understand that some things won't work as well. A good example of this would be if you were to bring narcotics with you, which, you know, that sounds like the wilderness party I want to be involved in, that we have resources that we're bringing narcotics and ultrasound and all this other stuff. That's prepared. But if you're bringing narcotics in with you, that pregnant patients are typically going to require higher amounts to deal with that, even if they're opiate naive. And that's true for a lot of things. Antihypertensive medicines are going to be that way. Almost everything is going to require higher dose. So while whatever the dose, especially as you develop in your careers and you get more into what you're used to and what your main deal is, you can assume that you're going to need, well, pediatric would need less, pregnant people need more. Okay, respiratory. So the respiratory system compensates for the physiologic anemia to maintain homeostasis. Progesterone stimulates respiratory drive and increases CO2 sensitivity. Therefore, you get a 30 to 40% tidal volume increase, 50% increase in alveolar ventilation, increased PaO2, increased 1 minute O2 uptake, and a large decrease in partial pressure of CO2. The overall effect is to increase the oxygen carrying capacity of maternal blood, and this helps to facilitate diffusion of CO2 from the fetus. And as you remember, potentially for medical school, but definitely for studying for MCAT, the hemoglobin affinity is higher in a fetus than it is in a mom. So the baby is always going to try to pick up more O2. And that's a common theme. The baby is typically going to take what it needs from the mom at the mom's expense. So that's true as we get into this next couple of slides here. We talk about weight gain and nutrition. The baby's going to take what it needs for the most part from mom. Urinary, increased frequency. Pregnant people pee all the time. So if you're going, again, these are all things to think about as you're planning your trip. And I specifically made this lecture from the point of view of a physician or provider that is going to be either part of some hiking expedition, camping expedition, hunting expedition, or the team lead or the medical lead from that standpoint. So these are things that I would think you should know and you should be thinking about and being understanding, so that as you're looked to for medical advice, you have an idea of how to act. Incontinence, that's a bummer. It's very common. Progressive decrease in bladder capacity and doubling of intravesicular pressure throughout the pregnancy. And this almost always resolves after the person delivers. Increased risk for UTIs. And this is important to talk about, as most UTIs in pregnancy, urinary tract infection, most UTIs in pregnancy are asymptomatic. So the patient will have zero common symptoms, like, again, they already have increased frequency. So is that from UTI or is that just from pregnancy? The UTIs in pregnancy specifically, they will usually not have dysuria. Therefore, if you have a patient with dysuria, the threshold to treat, and we'll talk about this in a minute too, the threshold to treat is very low. So if you have a patient that has any symptoms of a UTI, we would just treat them, especially if I had antibiotics on board in this situation and in this setting. I would have a very low threshold to treat, even though you want a culture. Yes, you want all that kind of stuff, and ideally you would want that from a resource standpoint if you had it. But assuming you don't have those things, if you're just like, boy, do I treat, I don't have a UA, you're gonna treat with a very low threshold. And we'll get into why that's important here at the bottom of the slide. Don't read ahead. Ureters have increased dilation, so there's more flow through them. Increased kidney function and filtration, more flow through all of this. Physiologic hydronephrosis happens, there's so much more flow, and increased risk of nephrolithiasis and pyelonephritis because the gravid uterus dextro-rotates. So it kind of rotates to the right and back, almost like this gangster lean that ends up being right on top of typically the right ureter, but it affects both ureters. So if a pregnant person specifically is laying straight on their back, that's going to get the most pressure, compression. It also compresses the vena cava, which is not ideal either. But from a blood flow standpoint, and again, we'll just put this in the back of your mind, if you're trying to maximize blood flow to a baby, the mom laying on her left side, right, takes most of that pressure off. But back to this, you have all this extra filtration, but then you have this compression of the ureter. So you have this hydronephrosis. Anytime you get an ultrasound, an x-ray of a pregnant patient, especially in the second, third trimester, they will always have, the report will always show hydronephrosis. That is normal. How concerned are we just depends on the other issues, but that is always normal. So keeping that in mind, this is why that pyelonephritis as an ascending infection from a UTI, why we're so aggressive with UTIs, can kill a mother and fetus. That's right. So typically you have a pyelonephritis, and I don't do emergency medicine outside of the realm of OBGYN, but typically with pyelonephritis, you could give somebody a shot of Rocephin in the ER and send them on their way. With pregnancy, they're going to be on Rocephin, but they're going to be on it for 24 hours, and usually takes 24 to 48, sometimes 72 hours to get them afebrile and to clear the infection completely from a pyelonephritis. The point is they're hospitalized for that. This is not a treat and street situation. This is an evac situation. This is a patient that is very sick, even if you don't think that they are. If they have CVA tenderness, if they have pyelonephritis, full stop, this is somebody that needs to be hospitalized. Okay, integument, musculoskeletal. So increased estrogen leads to, and I won't bore you with I know it's hard, like some of the menstrual cycle. That's a different lecture. But increased estrogen leads to proliferation and dilation of small arterioles in the skin to compensate for increased maternal and fetal metabolism. All this heat that's being generated from this growing, some would say parasite. As an OBGYN, would never say that. But this growing little parasite is creating so much heat that you have to do something. The body is doing something, right? It's absolutely taking care of this as best it can, but there's now a limited capacity to adapt to further heat stress. That's pretty relevant because now you have an increased risk of hyperthermia in hot and humid conditions. Increased risk of skin damage too from estrogen from the sun exposure. So that definitely something to think about. Again, if you're trip planning, and we'll allude to this a little bit as far as what you're looking at and try to have some kind of planning from a prevention standpoint. But keep this in mind. If you're going to some place that's going to be hot and humid, and I'm in Tennessee, so it's hot and humid more months out of the year than not, that is where you have to really be thinking things through, because while some of the people in your group may be fine, the pregnant patient, which you're going to be like, oh my gosh, why is this pregnant lady even on this trip with us? You're going to really want to be thinking that through. Typical weight gain is 20 to 30 pounds. And there's a real range on this. It just depends on, where you're at. It's controversial, but some people, if they were like in the obese category, you could almost get away with I'm not going to officially say this, but you could almost get away with not having weight gain there and maybe even losing. Some people say they should gain a little bit, but the point is, it depends on where you're starting. And if you're a well-conditioned athlete, you may be at risk of a catabolic state if you're starting with less initial fat stores. So that's relevant because if you're about to go on this trip, this expedition, and you're a well-conditioned athlete, that's good from a cardiovascular standpoint, but you may need to be able to really account for calories. Now, for the most part, we're talking about like 200 calories extra a day. So it's not, some people get a little carried away and they're like, oh, I'm eating for two. You're not eating for two. There's not two human beings in there that are adults. There's one adult and one little bitty baby. So 200 calories is really all you need extra. But again, keep in mind, you have a tighter buffer. So if you're going to be doing exercise on this expedition and you're already at a low fat store, you have to really take into account for that from a metabolic need standpoint. The weight gain of the gravid uterus displaces the center of gravity forward, and that causes a progressive, as it keeps going, lumbar lordosis. So it's almost like if you ever remember back in school where you put backpacks on backwards, because that's cool, and you put it on in front and you feel all this weight pulling you forward, your body will naturally start to deal with that so you don't topple over, right? Your brain will automatically start to compensate for that. The problem is you start to get this really wicked lordosis, and the more that happens, the more low back pain you get, of course. But this also can lead to compression of sciatic nerves, and you get weakness of the buttocks and lower extremities. You can also have gait and balance disturbances that you might have had somebody that was a very well-conditioned athlete that was used to, like, jumping from rock to rock and just getting crazy. And then all of a sudden you now have this backpack that's on the front, right? That's going to really throw everything off that you're used to. So this can also lead to an increase in trauma. So there's also increased joint laxity from hormones. So specifically relaxin and progesterone. That causes a whole slew of potential issues for some people, especially if they already had some joint laxity to begin with. Fluid retention by the wrist flexor retinaculum. Oh man, we're really getting into some good medical school stuff right here. Can cause medial nerve compression. So you end up getting this carpal tunnel syndrome and therefore hand weakness. As you can imagine, that's relevant because A, it's annoying. Boy, so many things about being pregnant are annoying. If you haven't figured this out yet, pregnancy, not for everyone. But not only do you have to deal with this carpal tunnel syndrome that wakes people up in the middle of the night and they're just like, oh, what do I do? And we're like, we can try this splint thing, but it doesn't really work. The issue here is if you're rock climbing, if you're doing any kind of climbing, you're trying to, even if you're not just rock climbing, like, sheer rock face, if you're doing any kind of hiking or any kind of movement where you need hands to help you, this hand weakness sometimes results in people falling and trauma. So things to think about what you're doing. Okay, we're going to roll into obstetrical history taking. This is the typical way we do this. Age of patient. Hey, that's easy. We haven't deviated yet, and now we're deviating from the norm. Gestational age. So 20 weeks is the top of the uterus, which is the fundus at the umbilicus. So if you look at the umbilicus, if you were to push kind of on the patient's abdomen, working your way down, you'll eventually hit the umbilicus, right? Or you eventually hit the fundus. And where that is kind of a rough ballpark. If you had a measuring tape in centimeters, I don't know why you have a measuring tape. Maybe you do. Maybe you could put this in your kit. The top of the pubic bone, if you put that at 0 to where the top of the umbilicus is, if everything is growing the way it's supposed to, sorry, not the top of the fundus, not the umbilicus, from the pubic bone to the top of the uterus, the fundus, that number in centimeters should be about how many weeks they are. So that's kind of a handy thing to have an idea. But hopefully you're not just stumbling upon a pregnant person that's on your trip. Hopefully this person's had prenatal care and you already know where they are, and it's not just like this mystery that you're trying to put together. But that's the idea. 20 weeks is top of the uterus at the umbilicus, 36 weeks at the sternum. And interestingly, once you get to the sternum, the baby starts to drop lower into the pelvis. So 36 weeks or 36 centimeters, right, is about as high as it gets. So the sternum is as high as it gets. And then most of you are thinking like, wait a second, if the baby goes to 40 weeks, like where's the other 4 centimeters? The baby starts to drop lower into the pelvis. And so 36 is as high as you get. So you could have a 40-week baby at 36 inches. At the sternum, you could have a 40-week baby or 36, but 36 is kind of where you're at. So we want to know that gestational age. That's based off the due date. You can wheel that out. You can bring a wheel with you, I guess. You can do it on your calculator, on your phone. There's lots of apps that are out there for that are useful. There's also some quick, like Nagel's rule. There's a couple things to do. That's hard to remember if you didn't know. So if you have a pregnant person, let's have all this stuff ahead of time going in. That's the easiest way to do it. but we want to know that due date. And was that obtained by last menstrual period or ultrasound? And that's relevant because the further you get into trimesters and into pregnancy, the less accurate ultrasound is on dating and weight. It's most accurate in the first trimester, and then less so in second, and least so in third. So LMP, if the person has periods like clockwork, if they say, well, I think it was like, I don't know, I get one like every 6 months, that's not going to help you. So it depends. Ideally, LMP that has regular periods, LMP that is equal to first trimester ultrasound, that's what you're looking for. So if somebody can tell you that, that's useful. Obstetrical history, we typically do the TPAL format. So that's term, preterm, and we consider that like we're talking like after 20 weeks, because before 20 weeks, if they have a baby, that counts as an abortion. Elective, if it's elective, or spontaneous, but an abortion before 20 weeks is relevant because that's where it goes in the third category, right? Preterm, abortion, living children. And then sometimes these things can be off. If they had twins, they'll have, maybe they're a 1-0. I mean, if they made it past preterm for twins, which can happen, but a 1-0-0-2, I would assume they had 2 living children. So all of a sudden, that must mean they had twins, right? You'll eventually need to list out each pregnancy and its respective course. Like this person had a vaginal delivery at 37 weeks, and she said there's no complications. She had a C-section because the baby was, doing weird stuff on the monitor or whatever. These are all relevant things to get into the meat of the history that will help you understand kind of where you need to go and what, for one, if you're trying to come up with a differential when you get into some of the things that are going on in the issue or in the situation, but mostly just even if on the onset of the trip, if they don't have good prenatal care, having an idea of this is important to have an idea of what you're going to do and what you're going to need and kind of where you need to go. If you're getting into the history taking from the standpoint of HPI, right? So current pain, location, duration, onset, character, contractions, onset, frequency, severity. Nothing annoys an OBGYN more when somebody says, I have no idea if I'm having contractions. And I want to say like, well, I've never felt contractions before either, but I know if I was having them, and I've seen movies, right? You're like, oh, this person looks like they look like they're in pain, and it lasts for about a minute and a half, and then it goes away and it comes back. What's that interval? I don't know. So that's always important. So if somebody's having contractions or it looks like they're, grimacing or whatever, and it's an intermittent thing, time those because that's really useful. Vaginal bleeding, always important to know. And we'll talk about that in a little more detail here coming up. But is it spotting, just a little bit of spotting, or is it much more severe than that? So fetal movement, so generally relevant after 24 weeks. And I say that because, I mean, we're right now, depending on what the center you're in, 22 weeks is the cusp of viability. So things can maybe happen if the baby has enough weight and all that. But I would say from an austere standpoint of whether you're going to say, okay, we need to evacuate, that would be really important to do. Certainly, like from fetal movement standpoint, it's more significant after 24 weeks. You get into quickening, which is when people start feeling baby move. If it's a mom that's never had a baby before, they typically don't really know what they're feeling. So they don't really know the baby's like moving until 22, 24 weeks. If they've had a baby before, they're like, oh, these feelings that I was experiencing back in, 17, 16 weeks was the baby moving. So people can experience quickening 16, 17 weeks. But again, it's really only generally relevant after 24 weeks, because if the baby's not moving before that time period and it's died, that's sad, but there's not much we could do at 22 weeks if the movement stopped. So it's really only relevant that it's happening on a regular basis after 24 weeks. Vaginal fluid leakage is important because sometimes it's some kind of cervicitis, sometimes it's going to vaginitis, or it's their water broke, right? That's relevant, and any other symptoms. Obstetrical risk factors. So there's loads to go with that, but like essentially when you're asking the history taking standpoint, just ask the patient, hey, have you had any complications with previous pregnancies or any issues this pregnancy? Medical risk factors, like always, medical history, surgical history. Okay, so common pregnancy-related conditions. These are the common ones. There's a lot of them. So vaginal bleeding can be so many things. It can be totally normal. It can, again, if it's like spotting and it's really light, it's not that big of a deal. Versus abruption, There's placenta previa or vasa previa, placenta accreta. SAB is spontaneous AB, so spontaneous abortion. Retained placenta, postpartum endometritis. Do you have ectopic pregnancy, diabetes? So diabetes getting into DKA, we'll talk about that. Preterm labor, malpresentation, so breech or oblique or transverse, shoulder dystocia, hyperemesis, intrauterine infection, premature rupture of membranes, abdominal pain, UTIs, hypertension, and the old preeclampsia, vaginitis, multiple gestation, and then there's some special considerations we'll talk about specifically with high altitude and scuba, but in the other order. Okay, vaginal bleeding. So abruption of placenta. So this is where the placenta starts to separate from the uterine wall prematurely. Interestingly, you can have up to 50% of the placenta abrupt or separate before it really affects the baby in a negative way as far as like it dies or starts to bleed. So that's relevant because, I mean, you can have quite a bit of abruption and the baby still make it. Abruption is specifically a clinical diagnosis. So while you could do ultrasound, only about 40-ish% of abruption. So if you had 100 patients that had an abruption happening, you would only see it in 40% of patients. So ultrasound is not it's not an ultrasound finding. It's not a guaranteed thing. So the point is, it's a clinical thing. So the patient's going to have signs of abruption. So the patient's going to have the like one giant contraction typically, so like one really tightening of contraction. They will likely have, it's possible to have it without vaginal bleeding. They most likely will have vaginal bleeding, heavy vaginal bleeding with it. And they're going to be very tender palpation. It's going to be very uncomfortable. Placenta previa is the painless bleeding. So just like your chancre, your painless chancre is syphilis. Hey, there's a free one for you. I'm not even talking about that. The bleeding, the vaginal bleeding you get that is not associated with a contraction, it's not associated with any kind of pain, is more likely to be a previa. And this is where the cervical opening is covered by the placenta, or a vasoprevia, where a vessel from the previa is covering the opening. And this can result in exsanguination of the mom, death of the baby. If you have a previa and it starts bleeding, or a vasoprevia and starts bleeding, if you're in the hospital and across like the way from the ORs, there's a decent chance we'll save baby and mom. If you are on another floor of the hospital, baby's probably not going to make it, and mom might. If you're at home, or you're in, certainly we're not even talking about austere. If you're like parking your car in the hospital and this happens and this rips through, we talked about that 500 ml, right, per minute, it's not likely a mom or baby will make it. It's possible, but not likely. So if somebody tells you, hey, I'm ready to go on this Mount Everest expedition, which we'll talk about high altitude in a second, and they say, and you're getting their history and they say, I have a placenta previa, you can say, good day, there's no way we're doing that. It also would require a C-section if the person was, far enough along to save the life of baby and mom. Placenta accreta is where the placenta digs in or implants a little too far into the uterus. And when this happens, when the placenta is supposed to separate at the end, when the baby delivers and all this other stuff, it just doesn't. So it just stays there. And that's problematic because they just bleed heavily and they will exsanguinate there unless the uterus can be removed. Occasionally you have focal accretas or smaller ones that you can maybe do something with, but essentially when you think of placenta accreta, that means that's somebody that's going to need a hysterectomy on the back end. So let's see. Sorry if you can hear my dog out there. I'm seeing if I can get somebody to come get the dog. I hear him just crying around. I had several people that were in charge of keeping this dog at bay, and I can hear him. If you can't hear him, thank goodness, but I can hear my dog just going nuts in the back. All right, so spontaneous abortion, aka miscarriage, right? People call it a miscarriage, but a spontaneous abortion or a threatened abortion. Typically, if somebody is having vaginal bleeding, we call that a threatened AB, especially it's less than 20 weeks. So we have a threatened abortion is just having vaginal bleeding. if you start to see products of conception come out, or if you start to see something happen that's, you know, that is all things that can be diagnosed on exam, but also things that you can see on ultrasound. So if you have an ultrasound with you, there's certainly things you can do. The biggest issue I would say with AB, again, it's under 20 weeks. It kind of depends on when it happens, right? If it happens at my wife just saying, "Oh my gosh, yes, I'll get a dog." If it happens at you know, closer you get to 20 weeks, the bigger the blood loss is going to be, the bigger the issue is going to be. If it happens at 8 weeks, certainly it's significant emotionally and psychologically to the patient, but it's less of a huge issue for your standpoint. So if you have a patient that says, "I'm 8 weeks pregnant, I'm ready to come on this expedition," that's a thing that can happen. There's literally nothing that can be done anyway differently about it. And as long as all of it passes and they don't just free bleed, you're okay. If it doesn't pass, but the baby is dead inside, or a fetus, however you're going to look at it, there's risk of a septic abortion at some point. But that typically, I mean, we're not going to say this is a hard and fast rule, but that's typically 4 to 6 weeks down the road. So if they're real excited and everything's happened and they're pregnant, and then it happens on your expedition or it happens out in that austere environment, as long as their bleeding isn't really bad, as long as bleeding isn't really, really severe, they're okay. What's severe? Different people say different things. We typically tell people, if you're saturating a pad or completely saturating a pad or tampon, one per hour for 2 hours, that's enough to say, okay, you need to get, you know, higher level care. So retained placenta is diagnosed 30 minutes after of it not spontaneously coming out after vaginal delivery, or I guess C-section too. But you know, no surgeon's waiting 30 minutes for this placenta to come out. But so from vaginal delivery, you're waiting. It can be up to 30 minutes before it's retained placenta. Retained placenta sometimes happen. Sometimes you get an accessory lobe. The whole placenta comes out and you just don't know. And there's a little piece there. The placenta, you examined it looks really good. You can sometimes have an accessory lobe. And if that happens, it happens. And so sometimes those folks go days to weeks before they have any issues with bleeding. So essentially, if the bleeding is good and they're okay, you probably don't have a retained placenta, assuming you don't have ultrasound or you don't have a pocket ultrasound or something to look at. But it's something to think about if they just delivered, right? Or maybe this patient delivered, I don't know why they would do this, but maybe they would do this. Maybe they delivered like a week ago or 2 weeks ago. And they're like, wow, I knew I was going to do this expedition with you all, so I'm coming. You know, somebody's going to watch my kid. I don't know. You never know. And so they say, well, I'm going to do this expedition no matter what. This should be on your radar for retained placenta, things like that. It could happen if all of a sudden they start bleeding. More likely, though, it's a postpartum endometritis, which is our next one there. So you get this bad rip-roaring infection, and that typically manifests in infection, you know, like symptoms, right? Fever, heart rate, increased heart rate, but also in uterine tenderness, malodorous discharge. But you also then get this huge like postpartum hemorrhage type situation. So that should be on your differential there too. There's sometimes no identified cause. Sometimes people just spot, you know, maybe it's menses and they weren't really pregnant. They didn't really confirm it. They just, you know, you never know. Some patients have a real weird idea of how they think you confirm pregnancy, which sometimes is very different than how I think you confirm pregnancy. Recent sexual intercourse. So the cervix is so friable second, third trimester that you could check somebody's cervix. You could have somebody have sex, not with their cervix, but their vagina. Oh yeah, this is getting weird. You have somebody having sexual intercourse, and that bumping of the cervix is enough to cause some spotting. It's usually not more than that, but sometimes it can be a little bit more. So spotting or something like that, especially after being checked, or intercourse, very common and not really something to be concerned about. The austere provider's coagulopathy test, they used to call this the poor man's coagulopathy test, but as a OBGYN and feminist, I tend to avoid some of these words. But the austere provider's coagulopathy test is, you could take a red top tube, which are very inexpensive. The red top tube has no preservative in it. So the whole point of the red top tube is to draw blood and then spin it down, and then you separate the red blood cells from the serum. So it's a serum tube. It has no it has no anti-clotting agents in it. So it's just pure. You basically, if you were to bring this, which is not something that you can think about having in your kit, you having somebody having bleeding, whatever. Yes, you can't send it to a lab, but you can put this, keep it at body temperature for 5 minutes, and in 5 minutes it should clot. If they do, then they're not in DIC. So you have somebody that's bleeding heavily, and we're like in and out of it, and you're just trying to get an idea of where are we. Obviously, you're waiting on the evacuation. Maybe you have other things you're trying to decide if you want to pull the trigger on some of the more, I don't know, maybe you can't get an IV and you're trying to decide if you should do an IO, and you're just trying to see where they're at, right? If you're trying to get an idea, you can say, you can see if the red top tube clots. If it does so in 5 minutes at body temperature, then you're not in DIC at the moment. So you have at least a fibrinogen of above 50. Vaginal bleeding going on. So treatment is generally based on the severity of the bleeding, along with any known conditions, kind of like we talked about. Very light spotting without pain is not generally concerning, especially after cervical check or intercourse. Anything more than that requires further workup and maybe a sentinel event to something far more sinister. And that's what's hard about a lot of these conditions, is you just don't know. So should you go on a trip to begin with? I don't know. But if you do, and you're the lucky provider that's dealing with it, something to think about of whether, how fast you want to pull the trigger to get out of there. Speculum exam and ultrasound is needed. That's what I would do. But, that's me. Evacuate to higher level of care is going to be a lot of these things. If evacuation is not possible, monitor blood loss closely and work on getting help. And it's going to be just the normal resuscitation type stuff that you would do, again, depending on your resources. Ectopic pregnancy. So typically unilateral pain, right? Because it's in one of the tubes, more likely than not. But ectopic pregnancy can be anywhere, right? Anywhere that's not in tube. But typically where you're going to find it is in one of the fallopian tubes. And it's typically unilateral pain. Peritoneal signs, right? This is the one where if they were in a bed, you got pretty good resources out in your environment, but if they were in a bed, you would kind of tap the bed to see if shaking them really bothers them. So peritoneal signs, right? Because they have all this blood that's ruptured, especially in their abdomen. Acute neck and shoulder pain when lying down flat. And this is a good one. When you have blood that's a natural irritant that hits the diaphragm, so they're laying down flat, and they have all this acute neck and shoulder pain, as many of you are already guessing, phrenic nerve, right? Because the phrenic nerve innervates diaphragm, but also runs and innervates some little neck and shoulder action, right? So if you're starting to have neck and shoulder pain lying down flat, sitting up. So a lot of times when I go see somebody in the emergency department that is an ectopic pregnancy, right? And the ER doc has already like wrapped it up. Our emergency medicine folks here in Chattanooga are phenomenal. I don't know if any of you are listening, but for real, they really are. They usually have it all wrapped up in a bow, and I just get to come in and be like, oh, I'm going to do some surgery on somebody, because they've already done all this stuff to prove it. But typically you'll see these patients, like they don't want to lay down flat. Why? Because their belly is full of blood. And if you lay them down flat, not only do they have acute abdomen, but they will just go nuts when that hits the diaphragm and then goes up to neck and shoulder pain. One time I had one that was absolutely an ectopic pregnancy, and I was debating whether to take her back, because I'm like, oh, is this rupture? She seems so good though. She looks so good. She didn't have an acute abdomen. She looks so good. But eventually I said, you know what? I was like, no, ultrasound looks like bad enough. We'll do it. And the patient was like, yeah, let's just go do it. She was so chill. She was so like just tough. As soon as we laid her, and it was bad on me because I didn't lay her down flat to the exam. We get back, anesthesia says, okay, lay down flat so they could intubate her, right? They could put her down. As soon as they lay her down flat, she comes off the table with pain. And I was like, oh, well, clearly. And then once we got in, she had a belly full of blood. But I remember thinking to myself, wow, this person really, her vitals didn't look that bad. I mean, she didn't look that bad. But if I just laid her down, that would have been enough to say, okay, now you look like everybody else. So she just was abnormally tough, high pain tolerance. So again, that's a really important thing when you're trying to do a good exam. And again, they're going to have an acute abdomen. It's going to be a surgical abdomen. It's going to be very obvious this is not normal. They may or may not have vaginal bleeding. A lot of times they do, but they don't always have to. So that's important to remember. It's usually life-threatening. I say only usually because it's like, 5% of the time, maybe not, but it's typically life-threatening. You're going to need to evacuate these people. There's really not anything you can do unless you're going to do, surgery on them to help, because you just won't know if they're getting that point. Is it possible that if they don't have it again, that there can be some tamponade effect? I've seen that happen sometimes in people that were misdiagnosed. It's crazy that I say, but it's true. And then you end up seeing them for one reason or another 2 weeks later, and you're like, whoa, you have a ruptured ectopic that just didn't kill you because it did tamponade. So that sometimes can happen. But to be clear, I'm not saying, you're probably fine. I'm just saying evacuate 100%, but like, there's a small chance that it may not happen. You're still evacuating, but if you can't, she may not die, but she probably will. Diabetes. Okay, so type 1 is going to be the bigger problem here. Insulin pump not working is a big thing. So you have this type 1 diabetic that's going to go out on the trek with you. It's usually a kink in the line or dead battery. I see that so many times. Insulin pumps are great, but I see this happen time after time. The demands of what your insulin requirement is in pregnancy goes up with each trimester. This is the other problem that is very problematic for a pregnant person that's going to go out in an austere environment, because if everything's going perfectly, they could still run into loads of problems with not enough insulin and having high blood sugars. So that's not even taking into account that maybe they're going to have more exercise, more. I mean, there's so many things that can throw off. So I'm not saying no type 1 diabetics can ever be out in the woods pregnant, but I'm just saying it is a real challenge, and there's a lot of pitfalls that can happen under the best of circumstances. So something to really consider and really be like ready to deal with. Another important part of DKA, and this I tell this to OBGYNs too, because a lot of OBGYNs don't know this, is that it's possible to have euglycemic DKA. I've had people in DKA with a huge anion gap, beta hydroxybutyrate, all this stuff is like legit. It's not like I wasn't wrong with it. It's legit. And there's loads of evidence that documents that euglycemic DKA can happen. So it's not just me giving you a little anecdote. It's real. I've seen it at 90 and 100. I mean, I've seen it at you're just like, how could this even be? But that happens. And it has all to do with the physiology when you get into some of the endocrine stuff that we didn't talk about with pregnancy. So just know that if they're looking DKA and you're thinking that, and you're like, well, it couldn't be because the blood sugar is all only 150. Oh, okay, that's plenty. Could be. So that's a tough one without having all the things. I mean, pregnant women sometimes spill sugar in their urine. So I'm sure some of you are thinking out there, well, just drink her urine a little bit and see if you could, but it may not tell you anything. It's very dangerous to mom and baby, right? Like that acidosis can absolutely kill both of them. It's difficult to accurately diagnose an austere environment with limited resources. So keeping it in your differential and evacuate early is important. Type 2, HHS is not very common, but is very dangerous. That's going to be something similar to a DKA kind of thing, but your biggest clue is going to be they're obtunded. I mean, there's like a urine test. There's things you can do, but in the austere environment with limited resources, if they're obtunded and they're a type 2 diabetic, could be a lot of things, but that should be in your differential of what's going on, especially if they have. Now, they're going to have like crazy high blood sugars, like greater than 600 kind of thing. Preterm labor. So 23, it used to be 24 to 36 and 6, but basically less than 37 weeks is preterm labor. The danger is inversely proportionate to gestational age. So the closer you get to 37 weeks, the better the outcomes. The earlier you are, it's a big deal. I mean, once you hit 28 weeks, like up to 28 weeks, every day makes a difference. After 28 weeks, every week kind of makes a difference to about 32, 34. But ultimately, from an austere environment standpoint, you got to just be very careful with this. The other tricky thing with preterm labor is that usually it's going to be cervical dilation with cervical change and in the setting of regular painful contractions. The good thing is that most of the time that's what you're going to see. So it's going to be fairly obvious and you're going to be like, well, she's contracting. She's only 34 weeks. Like, this is not normal. We should probably get her out of here. I would say in an urban environment, so you have something to compare to. Regular painful contractions 10 minutes apart for an hour should prompt the patient to go to the hospital for evaluation. That's if I have a patient that's like 30 minutes away, right? Some people will say for 2 hours or whatever, but still, if I have a patient that's 30, 45 minutes away, that's what I'm thinking. So you have an idea of where they're at. If you're 2-3 hours from evacuation, it's hard to say how long I would sit, before we really saw it, especially if they were really, really painful. Now, and that's also plus minus whether you're going to check this person's cervix. And again, to no fault of your own, it'd be different if an OBGYN is there who does this all the time. But if you don't do it all the time, it gets really weird because you're like, how good of an exam are you going to do and all this stuff. So that's also not ideal to do a lot of checks if you don't really know what you're doing, because that could cause issues. So adjust your evacuation plan accordingly. The course of preterm labor is very unpredictable. Sorry, I wish I had better advice for you there. Subsequent deliveries are typically much faster than their first delivery for anybody. So if you have a history of preterm labor and they're not on vaginal progesterone, even if they were, that's a risk factor. If you get a patient that you're taking on this trip that's preterm and she has a history of preterm labor now, that's something to think about. If you really want that person on your expedition or not, I would say no. But if not, depending on like how easy it is to evac, that's something you got to really like, one sniffle of a contraction, I would probably get them out of there if it was a difficult evac. Labor, so greater than 37 weeks, cervical dilation and cervical change in the presence of regular painful contractions. That's easy. In a nerve environment with greater than 37 weeks, 5 minutes apart for an hour. So again, some people say 5 minutes apart for 2 hours, but I say 5 minutes apart for an hour should prompt patient to go to the evaluation. If they've had multiple vaginal deliveries though, I would go back to the 10 minutes apart for an hour kind of thing. I want to be much more conservative because it's going to happen faster than the first delivery. So especially if they had a fast first delivery, strap in, buckle in, friend, because this is going to be even faster. So you really want to take these things into account, whether you want somebody that's had 6 babies really fast and now they're 39 weeks going on your trek. All right, how to deliver a baby. Might as well talk about this. Number one, stay calm. The calmest person in the room should be you. After all, you're not pushing a baby out to your vagina, so just take a minute. Let the baby and the mom do the work, right? And that's an insider secret. I still want to get paid for what I do, but they're doing most of the work. You want to just gently guide. So try to avoid the baby just popping out. And that's more from a vaginal tear standpoint. I mean, honestly, again, it happens all kind of naturally on its own. And that's one of the things that I tell whenever we have the EM residents rotate through our area. This is one of the things I'm like, the good news is every time I've ever gone to the emergency department to help with a baby delivering, they already have delivered and really nothing needed to be done. So playing the odds, it all kind of happens naturally. That's the good news. If it doesn't, you're probably screwed. But if it does, which it likely will, you'll feel really good about it and it'll all kind of work out. You do very gentle downward pressure, guiding the baby's head down and then up. There really is no pulling because that's where you get into brachial plexus injuries, right? It's all gentle guiding down and up. There's not a lot you can do. There's things you can do with somebody who has an epidural as far as like protecting the perineum and all kinds of things that little extra things we can do. But you're out in the woods, you're out on the side of a cliff. There's no way you're going to be doing a whole lot anyway. So that's the good news. And the biggest thing I would say is that 93% of the time, it works every time. Meaning that, and then we're not getting into a home birth debate and delivery kind of thing, but this is the idea that it does work a lot of times really well and naturally. It's just when it doesn't, you need somebody to be able to get in there immediately. And sometimes there's not enough time. So my point is I wouldn't ever recommend going out to an austere environment and just having a baby. Plenty of people do. But it's a gamble, right? It's all risk versus benefit. It's a risk assessment and how much are you willing to risk and how much are you willing to do it? If you say 7%, of my baby dying and me dying is a risk I'm willing to take, then that's a risk you're willing to take, right? As the provider, that may not be a risk you're willing to take, so consider that. Focusing on maternal breathing and pushing the pain away is often the best way to the finish line. Almost 100% of the time, the mom at some point will say, I can't do this. It's almost a given, like it's almost 100%. And that's where your proper encouragement goes a long way. That's where you're going to say, you can do this. People have been doing this for thousands of years. You can do it. You will do it, and be really, really encouraging. And then boom, they'll do it. You ideally want to push when you're having a contraction for maximal effort and efficiency. That's easier said than done when somebody's going natural. So sometimes they can do it, depends on the person. Sometimes they can't. And if they can't do it, that's, they're going to do what they're going to do. And eventually that baby's going to come out. After the baby comes out, place the baby on the mother's direct skin because you want that warmth, right? And if you're in a situation where it's very cold outside, on their direct skin, and then, lots of stuff on top to keep the warmth in, but you want that skin to skin. That's really, really important. Vigorously dry and stimulate the baby, so important. A wet baby is a cold baby, and a cold baby is a dead baby. After 60 seconds, you can clamp and cut the cord. If it's a full-term baby, there's some advantage of doing the delayed cord clamping. There's not a ton, but doing it more than 60 seconds does not help. Doing it until the cord stops pulsing does not help. People like to do this, whatever. I'm just saying the only thing that happens after the 60 seconds is no advantage to the baby. and mom has more blood loss. You clamp the cord if you have two Kelly clamps, or you clamp the cord with shoelaces. Don't ever use your own because you got to be able to walk around, and shoelaces versus no shoelaces always wins in an argument. But you could use paracord like 550 line or whatever to tie off, and you're going to cut in the middle. Your whole point is you're trying to prevent exsanguination from the mom while the placenta is still attached, and the baby while the baby's still attached. Theoretically, these things should kind of stop on their own, yes, but I mean, come on, let's not take it to the chance. Let's not waste a drop of blood if we don't need to. Nipple stimulation or breastfeeding will encourage oxytocin letdown from the posterior pituitary, and that can help with contractions. You'll see some of the stuff, and even looking in, I'm looking over here because I have our box books. Will say it's part of your med kit list to have like oxytocin, but it has to be refrigerated for a period of time. It can stay out for a little while, but not for your week-long trek. Methergin and hemabate, which are, methergin and ergotamine, hemabate's prostaglandin F2 alpha. Those are not things that you can really have out for a long period of time out of the refrigeration. Like you can for like 12-ish hours, but not on your long trek. So if you're going to bring it along, you'd have to bring it in some kind of cooler, which you could do. It's just refrigeration. But, again, you may not have thought that far ahead. If you were going to do it, you got to keep it refrigerated. The placenta will typically come out on its own with maternal uterine tetany, so the maternal contractions, one giant contraction within about 10 minutes. Sometimes it's earlier than that. You have a retained placenta at 30 minutes. If it hasn't come out at 30 minutes, then it's retained. And if it doesn't come out with genital traction at that point, you would need to do a dilation curettage. So that's going to require somebody to be certainly out and about. Alternatively, so tie off any bleeding vessels and close any vaginal lacerations, assuming you have some kind of anesthetic, because they're going to need that. That's something that I would consider doing. It depends on your level of how comfortable you are. If you can at least tie off any bleeding vessels, that would be the biggest thing, because the rest of that can be repaired when you get them evacuated. Alternatively, hold direct pressure, right? You could also do that till you get them evacuated. You can pack a wound, but bear in mind that a vagina is like much, obviously the baby just came out through it. It's much more stretchy. So you're going to have to put a lot of packing in there to do that. Packing a uterus is the next level of difficulty because that also will stretch out. And so if you're not used to doing that or having that kind of sensibility about you to do it like an OBGYN would, that's again difficult, meaning you could do a little bit and just haven't done enough, and then it just continues to bleed behind it. So if you can do it, it can be packed, but you have to pack it tight. Uterine massage, hard and vigorous, goes a long way to increasing uterine tone. That's like your number one thing you can do. And if you just had to do that constantly until your evacuation comes, I mean, that's what you would do if you were doing CPR on somebody, right? So that works really well. Malpresentation. So if it's breech presentation, do not pull on that baby. Let it come out. Let maternal expulsive efforts drive the show. Once the baby's body's out, wrap it with a towel, support the baby because the head's still in. Sweep the arms downward in motion next to the baby's hips. Allow the baby's head to deliver. And you're going to kind of have to like sort of move the baby sort of with the direction that it needs to kind of come out. But that should all happen on its own. Shoulder dystocia. This requires a complex set of maneuvers that only the best OBGYNs can do. But seriously, in the most difficult of cases, fortunately, though, 80 to 90% are resolved with sharp leg hyperflexion. We're going to see this in just a second. We'll place the mother's thighs to her chest. Suprapubic pressure towards the direction where the baby's head is facing, not on the pubic bone. It's suprapubic pressure. If you push on the pubic bone, you're just pushing it harder into the shoulder. I'm trying to push the shoulder behind the pubic bone away so that it forces the shoulders inward. Delivery of the posterior arm, because usually you're trying to get the anterior arm out first in a typical delivery. That's not working, so I'm going to try to get posterior arm out, and that makes a little bit more room to drop down. Look on here on the left, you can see this is getting that steep flexion of the hips to open up that sacrum to pubic bone. And then on the right, you can see the suprapubic pressure. They're behind that pubic bone, trying to push that shoulder in. Hyperemesis, up to 2% of pregnancies. And hyperemesis gravidarum is persistent vomiting and greater than or equal to 5% of weight loss. This is a huge problem. Short of this, hyperemesis or emesis is really common. Nausea and vomiting is really common. And typically, like I told you before, baby will take the nutrients needed from mom. So for the most part, mild nausea and vomiting is not harmful to the fetus, even though it's really annoying to the mom. and really annoying to everyone around her, because nobody wants to hear retching. You just feel bad for them, right? But the baby will generally take what it needs from mom at the expense of mom. Hyperemesis can have severe complications. And again, if you already had like low reserves to begin with because you're an athlete and you're attracted to doing things in the outdoors and things like that, you're in a tough spot. Fluids. If tolerating PO, IV fluids if not, and evacuate if you're probably going to need to evacuate, because antiemetics will basically work a little bit if it's nausea vomiting, but if it's true hyperemesis gravidarum, this is where people have like Zofran pumps and there's all kinds of stuff to it. So this is going to be evacuation standpoint. And then ondansetron, also known as Zofran, is controversial before 12 weeks. Okay, intrauterine infections, abdominal tenderness to palpation, malodorous discharge, leakage of vaginal fluid, contractions, maternal fever, and tachycardia. So they look sick, they seem sick. That's not good. Intrauterine infections, you need to get these people evacuated, because it's usually what happens is an intrauterine infection then will start to drive labor. So they usually have preterm labor or labor. It's not good for baby, and it's certainly not good for mom. But the body essentially views the infection or the pregnancy at this point as the infection source. So from a source control standpoint, the body is ready to evacuate, ready to jump ship. So it's ready to push that baby out. And so you will often come hand in hand with preterm labor and whatnot. So this is going to definitely be an evacuation situation. Premature rupture of membranes. Leakage of vaginal fluid, typically more than just one episode, increases the likelihood. If it's just one episode, maybe it was urine, maybe that incontinence we were talking about, it's usually small amounts of incontinence versus a big gush. It's usually a large gush. It can be a small amount. And if it's a small amount and you go hours and hours and hours and they actually are ruptured, that's not good. So this is somebody that I would lean on the side of evacuation on. Contractions are typical, but not always. I mean, oftentimes there's a big gush of fluid and then contractions afterwards. That's pretty much slam dunk of what happened. If they don't do that and they don't follow the suit, which a good chunk of people don't, you might have missed a big infection you might have missed the precursor to a big infection that then causes mom and baby catastrophic consequences. Abdominal pain is very common, can be a normal finding. The severity is really important. Right? Your differential includes abruption, uterine rupture, infection, GIGU, uterine, labor, appendicitis, pyelonephritis, nephrolithiasis, constipation, obstipation, gallbladder related, choledochia. History and exam is going to be most important, right? So this is a tough one because it could be so many things. Round ligament pain is worth talking about. You can sometimes see this as early as 20, 22 weeks, but typically presents more in the 28 to 30 week standpoint. So the round ligaments, as you all remember, because you're all uterus aficionados like I am, are the ligaments that suspend sort of the top portion of the uterus. So as the gravid uterus gets more and more gravid, progressively gets bigger, it starts to stretch the round ligament on one or both sides. So this is, again, can be unilateral or bilateral. It's usually worse with movement, so position changes. So typically they'll say, not always, but typically they'll say, when I'm sitting down or laying down, I'm fine. When I sit up and I'm standing, I'm walking, I'm doing stairs, it's way, way worse. The treatment is Tylenol, abdominal support, kinesiology tape, if you know what you're doing. There's good YouTubes on that, work really well, and heat. But that's a pretty common one. That's more common than most of the sinister stuff. So especially if you're out there hiking around and doing stuff, this is a very common thing that they're going to present with. UTIs, very common. Typically asymptomatic, as I mentioned before, in pregnant patients, requires antibiotics, very low threshold to treat. So if you're going to carry nitrofurantoin with you, this is a very low threshold here. May ascend into pyelonephritis and life-threatening, as we talked about. Hypertensive disorders of pregnancy. This is one of the things that I subspecialize in. I think it's very interesting. They're very common. It's one of the top killers of mom and baby globally. This is so lethal internationally. And it's just because of the access to care issue. So you will often see lower extremity swelling in every pregnant patient, almost. It can be very normal in pregnancy. It could also be abnormal and a finding of preeclampsia. So it's really non-specific. However, facial upper extremity swelling, while it's not a diagnostic tool, is more concerning because that's usually not what you see in a pregnant patient. So somebody that's having blood pressure stuff and upper extremity swelling, boom. I would say you have a very low threshold to evacuate that patient. Gestational hypertension is defined as a blood pressure of systolic of 140 or greater, or a 90 diastolic or greater on 2 occasions more than 4 hours apart after 20 weeks. Before 20 weeks, we consider it to be chronic hypertension. Preeclampsia without severe features is gestational hypertension plus proteinuria. Doesn't really matter because we kind of all treat some of these similarly. If you have gestational hypertension or preeclampsia without severe features, that's going to be something that needs to be delivered at 37 weeks. So if you're on a trek, if you're doing something, the patient's 37 weeks or later, and they develop blood pressure stuff, guess what? It's time to get them out of there because we would deliver them at a hospital. And honestly, even if they have blood pressure stuff beforehand, this is not somebody you want in your trek. I would get them out of there, even though they may, you don't know what the level of danger is the issue. Preeclampsia with severe features is gestational hypertension, like we talked about, with any of the following: a headache that does not resolve with appropriate treatment, persistent right upper quadrant or epigastric pain, can be any of these, doesn't have to be all, any of these, vision changes, blurry vision, loss of vision, floaters, and then severe range pressures of 160. And in OB, we define severe range pressures of 160 systolic or greater, or 110 diastolic on 2 occasions more than 4 hours apart. If I have a patient that has a 160 systolic or a diastolic of 110, I'm going to check her blood pressure in 15 minutes. If it's still up, I'm giving her antihypertensive related medicine, and she now fits the category of preeclampsia with severe features. I would deliver this person, like induce them or do C-section or whatever needs to happen, at 34 weeks or whenever we found it, if it was after that. So to give you an idea, that's much more severe. We're willing to take the risk of prematurity to some extent to get this baby out, because the danger of them cooking longer is way bigger of a risk than the benefit of them reaching more further maturity. The only real cure is delivery, so evacuate. Vaginitis, ooh, pretty common. Vaginal candidiasis, also pretty much asymptomatic from an itching standpoint, they usually don't have itching in pregnancy. Typically presents with watery discharge, chunky white discharge, and vagina is tender and exam. You really are supposed to do a wet prep to look on the microscope to look at the yeast hyphae and budding. So that's how you really do it. But if you're out and you have some Monistat 7, forgive me, I don't know what the non-brand is for that, but off the top of my head, but it's over-the-counter medicine, is FDA first line. It's gross because it's really discharging, so patients don't love it. They prefer fluconazole, which is a pill, but just so you know, Monistat 7 is the FDA first line recommended treatment in pregnancy. Bacterial vaginosis, not an STI, malodorous grayish white discharge. You would, again, this is not something that's like super life-threatening. So it is gross for the patient. They don't really like it. The treatment is antibiotics, and there's a few different antibiotics you can use, like metronidazole, but it's not necessarily life-threatening. Now, trick, on the other hand, is a single cell parasite is definitely an STI. Shows you how old I am. I still know STDs. Malodorous white discharge, strawberry cervix on exam. Treatment is the same as the treatment for bacterial vaginosis. So that's the one saving grace. If you're like, I'm not sure if I saw this flagellated organism. All right, well, good news is it probably didn't smell right, and so we're going to treat that. Multiple gestations. Oh my gosh, you definitely don't want multiple gestations out with you on your trek. Risk is dependent on chorionicity and amnion and what they share, right? So mono versus di twins. If you're interested in that, we can talk about this later. But the short of it is, you don't want. They're almost always going to deliver earlier than singletons do. Some require hospitalization depending on if they're mono because of cord entrapment, things like that. This is not somebody that is low risk enough for you to even consider for your trek. Okay, potential contraindications for wilderness travel during pregnancy. OB risk factors. So extremes in maternal age. So teenage to over 35. I'm well over 35, so I'm not hating on age. I'm just saying in OB world, over 35 is not young. Vaginal bleeding, any vaginal bleeding this pregnancy, multiple gestation this pregnancy, fetal abnormalities or growth issues, so IUGR, intrauterine growth restriction, or macrosomia, so smaller, large babies. Because there's an underlying cause of that you don't want to be messing with out in the woods. History of gestational diabetes or hypertension, history of miscarriage, history of preterm labor or premature rupture membranes, because these are all things that are risk factors. They could happen again, so this is not somebody you really want to take this chance with. Risk factors at destination, so lack of access to care, high altitude, endemic disease area that requires live virus vaccine, right? So you have, you know, you're going to go somewhere, you need vaccine. There's no live virus allowed, vaccines rather, in pregnancy. Risk factors due to activity: high impact trauma, scuba diving. Plan of action. So think it through. Like, what do I do? When do I evacuate? So what do I do if this happens with this pregnant person? We talked about some of those things. When do I evacuate? You know, you should have a low threshold. I mean, that's just the reality of it, because there's so many things that are unpredictable with this that it may ruin the trip. But, you know, then the question is, should we even really go on this trip? Not hating on pregnant people, love them. It's half my business. But I'm just saying, it's something to really think about, like how much you want to get into it. Like the airlines have certain rules, but they're not really based on any kind of science of like, oh, 32 weeks, 34 weeks, or whatever they're going to do. A lot of it has to do with how likely you are to deliver, or how likely you are to have it, different issues. Your threshold for evacuation should be very low, and especially after 22 weeks, because something could be done at a hospital, depending on the resources, at 22, 23, 24 weeks. Special considerations. So scuba diving and high altitude with AMS, or without. Scuba diving, so limited scientific human data, but there's really cool animal studies. Unless you really like animals, then you're going to feel really sad for them. But survey with reported incidence of, this is humans now, a 5.5% increase in birth defects with mothers who were divers during pregnancy. But really not a well done study, if I may say, in the sense that it's just a survey and it's like really just kind of wild. It was all like selection bias. There's so much to this, but kind of interesting that that's what they saw. Animal studies. So rats, mice, hamsters in a hyperbaric chamber, increase in low birth weight, miscarriage, bubbles in amniotic fluid. So because we know nitrogen passes the placenta, so passes the placental membrane, premature delivery, abnormal fetal skull development, malformed limbs, abnormal heart development, changes in fetal circulation, limb weakness associated with decompression sickness, and blindness. Yikes. Sheep on long decompression dives. Now, I was telling this to my wife the other day, and we were just thinking about what it looked like. And I'm only laughing just because it seems silly. It's science, and I'm not saying, I'm not making any comments on, I'm not laughing about animals. It just was like a weird thing to think of, coaxing this sheep from the pen to the boat, and then like, we're going diving, you know? And they used US Navy dive tables to do a decompression dive. And they found that there were bubbles in circulation even when the mother ewes didn't show any signs of decompression sickness. So there's definitely something happening to the fetus. Temporary premature closure of the foramen ovale and ductus arteriosus, although it was temporary, that did happen. There was some real changing in the shunting that's not supposed to happen, right? That was interesting. So in short, don't do it. High altitude. Women with history of miscarriage, growth restricted fetus at risk for preeclampsia should not go to high altitude. It should be or. I mean, it doesn't have to be all the things. You don't have to have a history of miscarriage, growth restricted fetus, but any of those things. First trimester short stays, so hours to days at altitudes up to 2,500 meters. The Wilderness Medicine Medicine Society, WMS, has a little bit higher altitude that they offer for their guidelines. This is from our box, so this is just a little bit more. Just understand there's a little bit more of a range that people do, but first trimester. Later trimesters, short stays, hours to days, without heavy exercise pose little risk. Longer stays pose risk of preeclampsia, growth restriction, abruption, and intrauterine demise. So you got to really think, is this necessary? Plan for at least 2 to 3 days of acclimatization before mild to moderate exercise, and 2 weeks for strenuous exercise. But I don't know that long stays are really recommended. AMS, acute mountain sickness. So treatment does not differ in pregnancy. Data is limited, however, though, as far as safety goes. Descent and oxygen therapy are preferred. The sulfonamides, they're contraindicated in pregnancy prior to 12 weeks for the teratogenic effects, and then after 36 weeks for neonatal jaundice. But understand that if mom dies, it doesn't really keep the fetus alive, right? So do what you have to do. Just understand that the risks and benefits need to be really weighed. Equipment list: pre-travel risk assessment, OB and medical history, absolutely. Access to care en route and at destination, emergency evacuation insurance, review, because you're going to need it, review of common and emergent obstetric conditions, and endemic infectious agents and environmental risks. So again, really good pre-travel risk assessment is important. Supplies list: So clean towels, because again, from a baby standpoint, well, for one, it's obstetrics. It's going to be a huge mess no matter what, even the best of times, because there's so much incontinence. So definitely clean towels, surgical lap sponges, surgical gloves. The clean towels also, you really need to have at least some way to clean off and dry that baby and keep the baby warm. That's going to be key, because they lose so much heat through evaporation when they're wet coming out like that. Speculum, plus minus, whether depends on how comfortable you feel going to what extent, to what exam you're going to do. Kelly clamps, they're a little bigger and thicker than hemostats, and that's what we use typically for clamping the cord. It's just easy, and it's nicer for bigger vessels anyway, so I always carry a couple of Kelly clamps with me. 550 line or paracord, useful for a lot. It's useful for everything. That should be everybody's equipment list. The DeLee suction bulb, you can buy these over the counter, but they don't work as good as the hospital ones. So I'm not telling you to do anything that you shouldn't do. All I can say is the hospital ones are the ones you want. So wherever you would acquire those, find out where your hospital buys them, maybe. I certainly wouldn't tell you to pilfer any supplies from anybody, but the DeLee suction bulbs from the hospital, for whatever reason, I'm telling you from a parental, like, I have 3 kids, they work great. The ones you can buy over the counter at Target or other places just do not work the same. I don't understand, but they stink. Scalpel, I mean, you could have scissors and other stuff like that, but a scalpel is going to go a long way for a lot of things. Syringes and needles, local anesthetic. Again, you can carry some of these other injectables like Pitocin or oxytocin, or Methogen with ergotamine, or Hemabate, which is the prostaglandin F2 alpha. The only problem though is that you have to keep them refrigerated. So you could do that, whereas Cytotec, aka misoprostol, does not need to be refrigerated. So I would carry 800 of that. You get to the point where you can prescribe yourself some misoprostol, and you can do, they come in 200 microgram tablets. You can do 4 of those and just keep it in your pack. It's like 90 cents. It's nothing. So, keeping that in your pack actually is pretty useful. Neonatal mask and suction, ambu bag, uterine balloon, tamponade device. That's getting a little advanced. You have to have some comfort doing that. Maybe we'll do a class on postpartum hemorrhage, and I'll show you that at some point. They're useful. I probably should have that in my pack because I could use it and I use them all the time. But I don't know. Optional things: injectable narcotics, injectable Narcan, IV fluids, injectable antibiotics. Before we get into Q&A, comments and topics to avoid a public service announcement. So do not comment to a pregnant person about their size in any way, not even if you think you're being helpful. Just don't do it. You look really pregnant. That doesn't make people feel good. I know you're trying to be helpful. It doesn't. You can't even tell you're pregnant. That doesn't make them feel good too, because now you're implying they're so fat you couldn't even tell that they were pregnant, right? Again, that's probably not what your intention is, but they're very sensitive about these things. It feels really weird for pregnant people because their body is changing so drastically. So no matter what their size is to begin with, it's such a weird, bizarre thing. You just don't want to do it. You don't want to cross that boundary. Don't ask to touch the belly at any time. If the belly wants to be touched, it will present itself to you in a manner that will be obvious that it wants to be touched. But basically, it's because the person that owns the belly is going to say, you want to feel the baby. Then go for it. But until that happens, don't touch it. You'd be surprised how many people just touch people's abdomens. I mean, we do it all the time, but it's because we're more or less being asked by the patient to figure out what's wrong with them, right? As opposed to you just like at a bus stop and you're like, oh, wow, you look gigantic. You must be pregnant. Let me touch your belly. Don't do it. Temperature. The pregnant person will dictate the temperature of the room. There's no reason to even fight that. With that said, here are the references, and I'm happy to take any and all questions you have if you're still awake. Obstetrics and gynecology. Or nobody was there. I was on mute the whole time. How about that?
Thank you, Dr. Bossert. If anyone has questions, feel free to unmute yourself and ask, or you can put them in the chat and I'll read them as well if you prefer.
Well, I will tell you that usually happens because I'm so long-winded. Patients and everybody alike usually has nothing to say. Okay, we have a question. Have you had to use your obstetric experience in the wilderness? Hey, that's an interesting question. Yes and no. Typically, I didn't have to necessarily use it in an actual setting. It was more sitting around a campfire and talking about contraception. I find as an OBGYN, if I go get my hair cut, I'm talking about somebody's period at some point literally every time I get my hair cut, we want to talk about IUDs or their menses. And that just goes, I took an oath, so I take it as it goes. So no, I don't think I can't think of a time where I had to use it. Like delivering a baby, I've always wanted to do that. I want to deliver a baby in an airplane, and maybe a boat. That would be interesting. So again, it has to be organic though. I don't want, it doesn't count if I like set it up, I bring like a patient out to it. So I'm not doing that. But no, that's a good question, but I haven't had to do it. It's more just like chit chat about stuff. Because most pregnant people are, I don't know, you got to be kind of a little crazy to want to be wilderness medicine at this, or wilderness inclined with how uncomfortable you feel in pregnancy. So crazy in an interesting way. You know what I mean? But like, I'm just saying, I don't know that I have enough interesting friends that want to go hiking with me pregnant. But yeah, thank you for the same great presentation. I appreciate that. Anything else? I know it's long. I don't know. I'm sorry. It's just so much to talk about. We didn't even scratch the surface. There's nothing. There's so much more to talk about. But it's an interesting thing too. I'll just say this: if people are thinking about other things to ask, that's fine too. It's interesting that, again, there's so much more of I mean, just in general, women, getting involved in all kinds of sports, and women getting involved in all kinds of activities. So it's not that surprising that you see more women that are involved in these things as part of their lives to say, I'm pregnant, why let that stop me? And then it's a question of how open are we as providers to accommodating when we can some of these ideas. I mean, one of the things that I run into all the time is people that have birth plans, and it's some people really hate them, but for the most part, it's an interesting way for us to talk about what things are really necessary, and if somebody doesn't want certain things, what is my rationale for why I need them? Is it just because that's my training, that's my comfort zone, or is it because there's really something to this that actually provides a modicum of safety to the patient? And that discussion is really good. So I think it's really interesting to me when we start to get into more and more women in general. I'm always a big fan of women getting involved in stuff because it always benefits. I mean, this doesn't sound sexist, but again, it's coming from a feminist. The more we have women involved in other things, especially in the things that I've been interested in, it's always gotten better. And I just, for various reasons, but like being an OBGYN, there's more and more women in OBGYN. So there's more and more really good thought that goes into some of the things that we did that didn't really make a lot of sense, from lifestyle to, whatever. It's something really to I think, I don't know, behold. Anyway, so I think it's fantastic that there's so much of this. And again, I think I see there's an increase of people, some of my patients, slowly, more and more trying to push the limits of what they can do. Linda Jones says, what's your advice about skiing? Oh, that's a good question. A physician friend went skiing at 6 or 7 months pregnant. That sounds like something we would do. We're so dumb sometimes. So that's a tough one, because on the face of it, as long as everything goes to plan, you're fine. On the other hand, if you have an abdominal trauma because you fall or whatever, I mean, I've seen more abruptions from somebody being at a stop sign and getting rear-ended, not that hard, than I have for 60-mile-an-hour collisions, because we have an OB trauma team, and that I respond to when I'm doing my hospital shifts. And so I go to MVCs all the time, and it's weird. The lower impact things, or somebody has a ground level fall and just falls on their bottom, and falls off a step and falls on their butt. Those are some of the ones that you see more issues from. So from my standpoint, it's hard because I really want people to do what they want to do and live their life. But 6 or 7 months pregnant, that is a big risk. If everything goes to plan and you don't fall, then there's no problem. But if you do have a fall, that fall, that impact, and that speed with that, I think is really is something that totally could cause an abruption. And then the question is, how far are you from getting checked out if you did have an abruption, if you did have that happen? Are you 2 hours away? Are you 2 hours away from a higher level of care to do that? So I would say that the conventional wisdom there, and probably is probably true, I would probably avoid that, because if you just because of the what if, you know. All right, let's see what we can see here. Matthew says, any insights on focus usage on pregnant patients in pre-hospital situations and wilderness scenarios? Is that point of care ultrasound? Is that what you're saying?
Yeah, I was just gonna kind of ask you if it's like comparable to like hospital ultrasounds, like if you can actually diagnose patients and
Yeah,
will
if you
use
have
them.
yeah, it's a great question. If you have the right probe, right? If you have like that, like under 5, megahertz probe, like which, so you have, there's really 2 probes you see most of the time, right? But essentially the one that you're going to use to do a fast exam that you might, if you're in an EM setting and you're, comfortable enough using that. Now, the probes that are the higher megahertz that you usually typically use for like placing a central line, that's not going to help. But if you use the like less than 5 and ideally a curvilinear probe that you might do on a fast exam or something like that, yeah, definitely. And I would say I don't have one yet because it's hard for me, it's hard to not get all those like cool toys as they come out. But I've used some of these ultrasounds at conferences that are the pocket like butterfly, some of these like sort of smaller point of care ultrasounds, and with the right probe, it's plenty good. Now, if you have an obese enough patient, I don't know, maybe they wouldn't be out on some weird trek. I don't know. But if you have an obese enough patient, the penetration is difficult to get through the adipose tissue to really see what you need to see. But yeah, they work really good. And so in the right hands, which I would like to say it's only in an OB/GYN's hands, but if we're being honest, I've seen loads of family medicine. I've seen loads of EM people that have really, like a lot of these communities have really adapted and really picked up more and more ultrasound. We have an ultrasound fellowship here in Chattanooga for emergency medicine that is amazing. It's top notch, right? And so the limits that are being pushed by some of these folks, one of the docs here, Ben Smith, again, if you're interested in EM and ultrasound fellowship, it is top notch, phenomenal. But some of the things that people can do with it are really amazing. So I can't even just say it's exclusive to just how good I am. I really think it's fairly translatable. And so yes, to your point, I think you could do a lot with it. Now, the only tricky thing is, what would you see? If you know what you're looking for, you could pick up some certain things. And if the patient was, the right body habitus, you could. The only downside would be if you didn't see an abruption, it wouldn't necessarily mean that they don't have one, or or what have you. But I think there's some utility there, and especially if you did essentially a fast exam like thing on abdominal, you could maybe see some bleeding, right? That's some abdominal some bleeding in the abdominal cavity from an ectopic standpoint. And while you may not be able to really focus on the ectopic 100%, you might get some of it, and you certainly would get some. Hey, there's some fluid in the abdomen. That's not normal, and this patient has like a tender abdomen. We need to evacuate. So that's a great question. And yeah, so I've used some. I actually haven't used it in wilderness scenarios, but I've used some of the ones that people have been really marketing for that. And I think for sure, I think if I was going to go on a trek, I would take one for sure.
Thank you, Dr. Bossert. Thank you, everyone, for attending the lecture tonight. If you have any additional questions, feel free to throw them in the chat really quickly, else we'll probably close out here.
Awesome. Thanks everybody for your time. I appreciate it.
Yeah, thank you.
Bye. Good luck to everybody.
Thank you.
Thank you.